The title of my presentation is Painful Transparency, and that is being done. Maybe a little bit, one of the things that I do is I've developed a company where we have created a medical data recorder, like the black box in the airplane, and we are trying to use that here in the Radboud to get much more insights in how people are working in the operating room, and thereby getting a lot more transparency. My presentation will be around 3 parts: human fallibility. Humans make a lot of errors, and we have to take that into account. How do we take care that we do much more systematic learning in the operating room, and in the end, what does that mean for surgical education? Maybe first to start with human fallibility. I suppose many of the people here in the room know the report from 1999, To Err is Human, which was sort of, I think, a big start in thinking about safety in the hospital and in the operating room. If I look at the title, To Err is Human, I think you can state it a little bit more strict even. My statement would be it is not as much to err is human, which has a sort of forgiveness if you make a mistake. But we have to take the fact into account that people make mistakes anyhow. So any system that you devise around the safety of the operating theater, it has to take into account that people make mistakes all the time. You can try to prevent them, but in the end, they will always keep on making mistakes. And making mistakes when the consequences are hard is difficult. This is a statement from a famous Dutch writer, Multatuli. We hold it more against others to know our failures than to hold our failures against ourselves, meaning that even though you know making mistakes is hard, but knowing that everybody around you knows about that mistake is often even harder for people. And because of that, they don't tell the others what kind of mistakes they make. And I think that's one of the big issues in healthcare. If you take all the numbers of the avoidable errors that lead to death in the Netherlands and divide that by the number of surgeons and the longitude of their careers, you come to a number of about 4 to 5 people that have died at the end of a surgeon's life because of an avoidable error that he's done. That's sort of the statistics average on it. And I think if you look at it in practice, all surgeons, when they encounter such errors and all kinds of errors, is that they are completely aware of that they have done that error and that they learn from that, and that error will not be repeated again. But if we look at, so surgeons individually, they learn a lot from it. But if we look at healthcare as a system, since many of those errors are not shared that much amongst one another, as a system, we don't learn from it. It keeps under the cloth. So if we look at then the operating room, if we look at all the avoidable errors that are being done in the Netherlands, it's about 60% of all errors are done in the surgery part, in the operating room. If we, like I said, we have to change the system from individual learning, the mistakes that one surgeon made and that he learns from, towards the system that has to learn from it. And for that we have systemic learning. And one of the big examples is in aviation. It was Tenerife. Tenerife, it was about 580 people that died in that crash. And in aviation, it was the start of really thinking about how can we improve safety in that environment. This was about the case. I am a pilot in general aviation, and I think one of the things, there are many things to learn at this from the surgical profession. Tenerife, when the accident happened, before that there was a bomb alarm at Palma, so lots of planes had to divert from Palma to Los Rodeos, which was quite a small airport. And on this taxiway, there were many planes standing, so the Pan Am that had just landed, it was not able to immediately go to the taxiway and based from there be safe, but it had to backtrack all the way back from the end of the runway to the beginning in order to find a place on the taxiway that they could park their plane. At the same moment, and accidents never happen one at a time, but when something fatal happens, it's often a lot of accidents that happen. The captain of the KLM, he was in a hurry because he knew if he was not able to take off within half an hour, he would have to stay another day there because of the time constraints for his working hours. So he was in a hurry. There was a lot of fog at the airport at that moment, so nobody could see anything. And so while the Pan Am was backtracking, the KLM captain decided to take off, and one of the presentations already saw a Photoshop picture of that accident happening. If we look at what really happened at that moment, because after the accident, everybody had their own story about what happened. And by analyzing the black box and all kinds of other data that was able to be found at the accidents, they were in the end able to find out what really went wrong. This is an example, the first line. Roger, we are cleared for Papa Bacon, flight level 90 until intercepting at 325. We are now at takeoff, which means that the captain says, okay, I know where I have to go after I have taken off. I'm ready to take off. He hears at that moment from Tenerife Tower, okay, and then some static noise, and he takes that okay as an approval. He fires up the engine, and he starts to roll on the runway. A little bit later, Tenerife Tower, Papa Alpha 1736, report runway clear. That is the tower talking to the Pan Am Boeing, asking the Pan Am Boeing if they are already clear, to report when they are clear. And at that moment, the Pan Am Boeing says, okay, we'll report when clear. A little bit later, a few seconds later, you can hear on the cockpit voice recorder the flight engineer say to the captain, is he not clear then, that Pan American? So the flight engineer hears something that the plane is probably not away from the airport at that moment. And the captain at that moment says back, yes, I did. I did hear that he is gone. And a few seconds later, the Pan Am captain sees the plane coming. He tries to steer it away from the taxiway, and of course there's a big accident at that moment. Part of the crew of the Pan Am has survived the accident. And if we look at in detail what was the error that was being made in this case, is that if you look at all the black boxes that were available, this part, stand by for takeoff, I will call you, spoken to by the tower to the KLM captain, was not heard by the KLM captain because of the static noise that was being heard at the moment. Because all the planes have the same frequency and you hear each other. It's a unidirectional system. And I think also like in surgery, as in aviation, small mistakes can often lead to huge consequences. If we look at aviation, how we solve that, the rule nowadays is before you take off, you have to have heard your call sign and the words ready for departure. You say your call sign and you say ready for departure. So the airplane is not using the words clear anymore. In that case, the tower says, call sign, you are cleared for takeoff, meaning that in the full sentence you have to hear your call sign and the words cleared for takeoff, which can only be pronounced by the tower, because it's a command for action. And to take care that runway cleared is not misinterpreted by somebody as a message to clear it, to take clearance and to take action, is that nowadays when an airport leaves the runway, it uses the word runway vacated in order to take care that there's no misinterpretation on that part. The interesting thing, I think, is if you look at these three sentences, because every pilot in the world learns these and other sentences in his education, and he has to use it, and you correct each other by being very disciplined about it in using it. These three words take care that an accident like Tenerife will never happen again. But that can only happen if everybody is disciplined in using these kinds of things. Well, this is an example of my own, an accident that I created my own. It happens. I had this small plane, I was flying over the Netherlands. I had an engine failure, meaning my engine stopped completely and I had to find a small green field. And in this case, it was an error from my point of view, because what I didn't take into account was I flying at the final part of the day. At that moment, you have a sharp temperature drop in November, meaning that the air gets much more moist, and that's a problem for engines in some cases. So that in the end led to a way to change in the syllabus for new pilots, so they are much more aware of this risk for this particular type of plane, and that they take it into account. Well, surgery can learn a lot from aviation, but I think in the end, the work of a pilot is very different from the work of a surgeon. So you have to get back, you have to take a step back, not look at it directly in the way a pilot uses a checklist, that's the way the surgeon should use a checklist, but you have to take a step back to quality assurance. And based on quality assurance, look at how can you increase patient safety. Quality assurance is about the plan, do, check, act cycle. Plan the process using checklist and taking care that everybody uses it in the same way in order to make a predictable process. Do according to the checklist that you have made. Act being look at the results of your processes and see if they deviate the outcomes from what you would have expected, and act on all the deviations, and again go into the process, improve your checklist and do it in a different way, and again and again and again in an iterative process. What does that mean for surgical education? We know that many of the errors happening in the operating theater are errors based on non-technical skills, often in communication. This is an example of all kinds of claims that were being researched, where about a quarter of those claims were related to communication errors, and they were of the type that the surgeon thought that he had said something to his team, but he just didn't say it. Or he did say something, but nobody heard it. People that thought differently about terms being used and thereby creating miscommunication. And for that we have to adapt the plan, do, check, act cycle for healthcare, meaning that on the one hand you have to use things like crew resource management, training people in communication, training people in cooperation, training people in leadership in order to improve that. But if you start to use those things like checklist, you also need to use something like black boxes, create an objective knowledge about reality, how things really go. Research shows that more than 50% of all the operation reports from surgeons are not completely true, and not that they are making fraud, but the human memory is quite bad. What they did is they made videos out of laparoscopic surgeries, and later on they compared the report of the surgeon with the things that you could see on the video. And like I said, more than 50% things were being differently. And that is partly because we all have a different perspective. This is an image from Escher, which is not possible physically, because you look at it from a different angle, and then you see that it's quite different. And I think reality is like that. We all have our own view on reality. And by making an objective video and audio and sensory data of the patient and have that available when you want to analyze is important to feed the improvement process. If we want that transparency, we need to be able to be open. If we want to learn, we need to be able to be open. But to be open also means that you are not being prosecuted for anything you do wrong. Because like I said in the beginning, people make errors. So you have to accept that people make errors and don't prosecute them for it, because if you do, people will not be open. Pilots are not able to prosecute them based on, for example, the things that the investigation body has written down in their report. The judge is not allowed to use that information. Well, these are some elements of high reliability organizations. I won't go into detail due to the time, but I think part of the lessons that need to be learned in surgery is what you need, I think, is collective memory. Talk about errors and share them amongst each other. The example of Tenerife, and there were many, many more, are often talked about by pilots by remembering each other. How important it is to use your checklist and to do all kinds of things like that. Evidence-based processes, you need an objective view of reality afterwards to see what really happened and not what people think has happened. You have to have a team focus. Most of the errors in the operating room are not based on the skills of the surgeon, but based on the skills in working together as a team. And of course, an error does not imply guilt. Making an error is something that everybody does. When I do it in my consulting work, it means an error in a report. When a surgeon does, somebody can die, but it's the same kind of error that still happens. To round it up, the statement I had in the beginning, I think the most difficult part of learning in surgery is the openness about errors that are being done, because it is difficult, because it deals with human lives. But I think the only entry to really start improving, to make less avoidable errors in that area, is to start that openness and to share the stories about what went wrong. And with that, I like to stick.